Mr. LB is a 94-year-old male admitted to long-term care on February 6, 2015 for exacerbation of congestive heart failure and acute illness, which is pneumonia. Past medical history includes pneumonia, congestive heart failure, insomnia, hypothyroidism, hypertension, anemia, diabetes mellitus, urine retention, and depression. History of present illness. The resident is sitting in wheelchair upon approach. Interview was conducted with him. He is admitted status post-pneumonia and CHF exacerbation. On 2/9/2015, his heart-healthy diet was changed to a no added salt diet, which may help increase appetite and intake while minimizing sodium intake. PO intake poor but improving. Per nursing and CNA, the resident ate 100% of his breakfast and about 50% of his lunch. Resident states he is never hungry but eats as much as he can. He likes the meals so far but prefers foods that are not hard for him to cut. BMI below normal range, however, his weight is up 2.8 pounds in 4 days since admission, and the resident says his usual body weight is around 110 pounds. He is on daily weights due to CHF, no edema noted at this time, and he is on the diuretic torsemide. Due to recent change in diet and improved intake today, defer further dietary interventions. Monitor for changes in PO intake, labs, and weights for trends and appropriateness of interventions as resident recovers from acute illness. He is a thin, elderly Caucasian male, skin color normal for ethnicity, and he had no wounds or bruising. He is on a no added salt or an NAS diet. He feeds independently and he has no chewing or swallowing difficulty, but he is currently on nystatin for thrush. He's 66 inches tall. Current weight is 110.8 pounds. Admit weight is 108 pounds. He has gained 2.5% in 6 days, which is not a significant weight change. His BMI is a 17.6 with a classification of underweight. Labs are unavailable at this time. All medications are listed. He prefers his medications whole in applesauce, and pertinent medications include the ergocalciferol, glipizide, Chlorcon, levofloxacin, daily multivitamin, and torsemide. His skin is intact, except for a laceration on the great right toe due to excessively long nails. He has no signs or symptoms of infection, and the laceration is healing well. His inpatient medical course relevant to nutrition includes cardiac pacemaker placement and coronary atherosclerotic vessel graft. His needs are based on his actual body weight of 50.4 kilograms. Calories are 25 calories per kilogram, giving a total of 1,260 calories per day. Protein needs are 1.2 grams per kilogram for a total of 60 grams per day. And fluid is 30 milliliters per kilogram, which totals 1,510 milligrams per day. He has inadequate oral intake related to exacerbation of CHF, acute illness of pneumonia, and a self-induced hunger strike during his hospital stay, as evidenced by a BMI of 17.6 and a self-report of insufficient intake. The intervention, Mr. B's diet was liberalized from heart healthy to NAS to promote better intake while limiting his sodium. Monitor PO intake by observation and conferring with nursing staff and CNAs. The resident is on daily weights. Indicators include his weight and PO intake, and these are to prevent further weight loss and increase PO intake to greater than 50% at 3 meals per day.